example of how melasma can present. Sorry, I kind of skipped that. If we're looking at this slide, you can see the distribution of the pigmentation affecting the middle cheeks. This lady doesn't have it on the bridge of her nose, but there's a bit as well on her forehead. She also has a bit of acne with post-inflammatory hyperpigmentation, which is often the case because when we see our patients, they can have more than one reason for their hyperpigmentation. This is another example of melasma in a lady. This is again affecting the center of the forehead. You can see the bridge of her nose is affected. The tip is often spared. And this is again very typical of melasma. What happens in melasma? We have an overproduction of melanin by the pigment, which is taken up by the keratinocytes. So you get epidermal melanosis. So there is pigment in the epidermis. And we also have pigment in the dermis in many cases. This is more common in people who tan easily. Again, people between skin type 3, I would say even 3 to 5. There is a genetic predisposition to melasma as indicated by some studies. And again, we see it more in people who live in sunny climates. Why? Because there are known triggers to melasma. What triggers? Sun exposure. That's why you will find that most of the studies that I will actually refer to in my talk are either placed in India or in the Far East or from Mexico or from Spain. These are countries where sun exposure is essential. Pregnancy, hormonal effects, taking contraceptive pills, medication, as we mentioned earlier, and hypothyroidism. In the GCC states, we have high incidence of hypothyroidism or thyroid disorders, in particular affecting the female population. I don't really have an explanation for that, but a lot of the women I see in my clinic usually are hypothyroid and for one reason or the other, and they are actually taking hormone replacement. So all these factors are very important. We have to take a good history when we see our patients to help find the underlying causes of such issue. Types of melasma, as we all know, the melasma usually we have, we can divide it easily according to the textbook to epidermal, dermal, but to be honest, in a clinical setting, usually we stand a bit confused and we end up saying that we think it is more of a mixed type of pigmentation. Now, with the epidermal lesions, the spots are usually light brown. They are well-defined margin. And when you examine them, you can see there's a clear hyperpigmentation that is very visible. Again, if there is a dermal component and you're trying to examine them with your wood lamp, then the color of the spots starts to range from turning from brown to more of a light blue or a grayish color. And this is actually what gives us the evidence that there is a dermal component to this pigmentation. And usually the margins are ill-defined. So it is not very clear, defined margin of pigmentation. Now, again, mixed types, the spots are usually dark brown, less uniform. There's more or less with more or less pigmented areas. This type of melasma has hyperpigmentation located in both areas, which is the epidermal and the dermal. So that is a mixed type of melasma, which I think is probably the most common type we see. The intermediate type, I think this is the case where you basically cannot classify the patient you're seeing, or you cannot put them in a category. And this is usually when you are faced with melasma in a darker complexion. Again, people in the GCC, we have a lot of people who their skin type ranges between 4 and 5 and going to 6. And to be honest, these are probably the hardest people sometimes to examine. Now, how do we treat melasma, or how do we target melasma? I'm gonna go in my talk, and through my talk, I'll talk about so many treatments and all the options, but I'm gonna try to give you some clues on what you can use in your clinic. What can you tell your patient to do? Because it's not always about treatment. Sometimes it's just about what the patient can do on their own, because hyperpigmentation is not a curable thing, something that will probably recur or relapse, and then we are always thinking of what else we can do. There has been a lot of studies about hyperpigmentation, and a lot of them speak about sunscreens. Are sunscreens enough? Is it a useful treatment? Actually, most of the studies that actually talked about sunscreens to treat melasma have shown that actually sunscreens are very effective even on their own. And that in its own is a very good thing, because it's very simple to tell your patient that using a sun protection cream with a good SPF is essential. And most patients can afford to have a sunscreen at home. It is very important to tell them that they have to reapply it at least every 2 hours. They have to be very consistent and never leave the house without it. It is also important to let them know that ultraviolet light plus the visible light can both contribute to melasma. In this study, for example, which was conducted in India, 100 women with moderate melasma were treated just with sunscreens, and they were told to apply it 3 times a day, every 3 hours for 12 weeks. Actually, there was a 26% reduction in the melasma score, and there was a significant improvement in the quality of life of these patients. Most women we see, it's just they're too embarrassed to leave the house with these pigmented lesions on the skin. And most of them, when they come, actually, they ask me, what can I do? And a lot of them cannot afford to do more treatment. So maybe the least you can advise them is use sunscreens on a regular basis. And you can be reassured that this will actually produce improvement. Again, this is another example of melasma that can be only controlled by using sunscreens on a regular basis. Now I move to hydroquinone. Hydroquinone, which is well known, it's probably the most common and most famous and the oldest and probably the most effective and affordable treatment that was ever invented for melasma or hyperpigmentation as a whole. It's a tyrosinase inhibitor. It no longer has the 3 months restriction on its use. Glycolic acid and tretinoin has been combined in different formulas with hydroquinone or even in separate treatments to help increase penetration. If we are using hydroquinone, the response is usually could be seen in 3 to 6 weeks with a maximum benefit over 3 to 6 months. Side effects, irritation, ochronosis. However, these should be rare under medical supervision. Usually, if the doctor is prescribing it and you are following your patient, you shouldn't see that. You can even advise your patient how to avoid getting irritation and ochronosis. Exogenous ochronosis is probably what we are all concerned with, and I'm sure as a dermatologist all over the world, wherever you dealt with hyperpigmentation, you must have seen cases of exogenous ochronosis, and that is common with high concentrations, common with less supervised patients, and actually common with formulas that are obtained from non-medical sources, where people usually get them from their local grocery or get them from people who sell cosmetic products at home. And that is actually probably the main worry with such ingredients. There was a study that was conducted on 48 patients in Brazil, and patients were treated actually with hydroquinone 4% and compared that to a placebo twice a day and using sunscreen. 40% of the hydroquinone groups and 10% of the placebo, they have shown total improvement. Now, 57% of the hydroquinone group and 58% of the placebo group had partial improvement. In this study, they've used subjective evaluation method. So actually, hydroquinone is definitely effective in treating patients with melasma. It is actually well tolerated by darker skin types in sunny climates, because most of the studies are actually conducted in hot climates on people with darker skin types. However, it is almost all the time combined with sunscreen use and a good moisturizer to hydrate the skin and avoid irritation. Now we move to the triple cream formula, which is all the mixes that are very popular and very common in all over probably the world. I think Bahrain is one of them. We have a lot of people who've been trying this, they call it here the mixed cream. It's usually a combination of a topical steroid, hydroquinone, and a form of retinoids. The formula can vary from one place to the other. The mechanism of action basically depends on the fact that tretinoin facilitates the epidermal penetration of the hydroquinone. The hydroquinone decreases the melanosome transfer and reduces the atrophogenic effect of the steroids. The topical steroids, they help to reduce irritation caused by the tretinoin and decrease the pigmentation on its own. Now, most patients are advised to do a daily application for 5 to 7 weeks. Now, everyone who treats hyperpigmentation must have tried it. We've all seen patients who've used it at least once in their life. Now, is it a safe formula to use? It is safe if it is done under supervision, if the doctor is monitoring the patients regularly, you are looking for side effects, and you are advising your patients accordingly. Now, in this study, there was a treatment of melasma in moderate to severe cases where they used triple combination cream, and they alternated that with basically glycolic acid peels. These patients had a total of 6 two-week cycles of the triple cream formula, and the 5% glycolic acid peels were used. And more than 90% of them showed improvement by week 12, and the treatment was well tolerated. So this tells you that actually you can use the triple cream formula as a pre-peel preparation cream, or can be used during a protocol of alternating with peels like glycolic acid peels. This all depends on your own experience, on where you practice, what is available, and what is again affordable to treat your patients. There is something new about hyperpigmentation, and maybe there's a lot of talk about the tranexamic acid in the treatment of hyperpigmentation. I personally had one experience with this. It's considered to be a plasmin inhibitor and antifibrinolytic, so it basically has an effect also on the blood vessels. It's been FDA approved in 2009 for menorrhagia. It is also used basically in intraoperative and trauma-related hemorrhages. Now, over the counter in some countries, and the patient I personally treated, she got it from the UK because it was available. Widely used for melasma also in East Asia, like Japan, Korea, and Singapore, and it comes in a topical, intradermal, and oral formulas. This is a patient that I actually attempted to treat. She used the oral tranexamic acid at the dose of 250 milligrams twice a day for 3 months, and she received 6 sessions of intradermal tranexamic acid, which I administered in my clinic every 2 weeks. I also advised her to use sunscreen on daily basis. You can see there is an improvement in the region. A patient was not extremely happy with the outcome, because usually these patients have very high expectations, and a part of the issue with treating facial hyperpigmentation is actually managing your patient's expectations. And it's very important that what I said at the beginning, that you're that we want to make sure that we are not basically, we know what we're dealing with, what is the correct diagnosis, is it melasma, is it something else? If it's melasma, what type of melasma or what level of melasma? It's very, very important, because you need to meet your patient's expectations as much as you can. Sometimes it's impossible though. Now, are there any other treatment modalities for hyperpigmentation that do not include tretinoin or hydroquinone or topical steroids? Yes, actually, most of the cosmeceutical companies have been actually producing a lot of new products based on more or less natural ingredients that are hydroquinone free, which can help with pigmentation. Probably vitamin C or ascorbic acid that comes in various forms has become very popular in the last few years. A lot of companies have produced various creams, serums, and lots of their products containing vitamin C that works as an antioxidant and an anti-pigment. It inhibits pigment production, and it is well tolerated. However, it is unstable, and that's why it is combined with other agents. There are also new agents that are already in the market and still under investigation, like the licorice extract, like the resveratrol, miquinol. Most of them are actually antioxidants. They are all, the good thing about them, and they all can be used as a skincare regime. Most patients can even buy them over the counter if they are well informed, or if you meet a good skin salesperson in the pharmacy you walk into. However, most of these treatments are very mild. They might help as a maintenance, but for acute cases or very severe cases that haven't been treated in the past might not make a huge difference. However, they're very good as adjuvant treatment or a follow-on treatment. This is an example of one of my patients who actually is a European lady who lives in Bahrain. She's had a good share of sun exposure. She came to the clinic asking to get rid of the blemishes on her skin. She didn't like that she had a bit of sun damage. You can see a bit of photo damage. She also gets the occasional acne that leaves her with post-inflammatory hyperpigmentation. However, this lady didn't want to do anything dramatic. She didn't want to do lasers. She didn't want to go overboard with her budget. So she wanted to have good products that she can use regularly and do a treatment that will be within her budget. So what I offered her is vitamin C based products, a sunscreen, and I actually offered her glycolic acid peels 30% once a month. This lady received 6 treatments, and you can see the before and after. There has been an improvement in her skin. This particular patient was very pleased with the outcome. She was very happy with the fact that her skin looks clearer, and she also commented that she gets less breakouts and less acne now, which meant less post-inflammatory hyperpigmentation. And this is just to give you an example how we can manage people sometimes with minimum products, even hydroquinone free if you're not keen on using hydroquinone, and at the same time give them a good outcome. And this is something she can continue to do on her own even when she stops coming to your office. This is the same lady where we use basically a skin analysis machine, and you can see the photo damage and the pigmentation, but you can tell that there has been an improvement before and after. Clinically, it was very satisfying to the patient, although with the skin analysis, we can still see that there is a lot of sun damage and photo damage, which could be improved with further treatment if she chooses to do more treatments with us. This is another lady who also presented with a bit of photo damage. She had a little bit of freckles. She had an early melasma starting on her forehead. She wasn't very happy with her skin. She's still young, and she said, if I don't do anything now, this is going to just get worse. And she's right. If you start early, you can actually help the skin to clear. You can correct the damage that happened and give them a better skin for longer. And again, I started her on vitamin C based products, gave her sunscreens. And this lady, I actually offered her treatment with a Q-switched Indiac laser once a month, and I gave her 3 treatments. And you can see actually, especially with the forehead lesion, is that actually the forehead lesion has cleared. I don't have a pointer here, so I'm just asking you to look at the forehead, and you can see that the pigmentation in the before photo has disappeared in the after photo. So the message can plan a treatment for them. Is open to the fact that they want to do something for the skin to improve it, then you have a chance to actually plan a treatment. The treatment plan varies from one patient to the other, and with the more cases that I will show you, there will be more and more examples of how you can actually vary your treatment plan. Again, this patient skin analysis, as I told you, shows more than the skin analysis itself, but what matters is what your patient is happy with. Now, the general advice with these patients, now, oral contraception is not a popular method of contraception where I live, but I know it's a very common contraceptive method, especially in the West. And that's why when I see in my clinic patients who are expats or from spectrum sunscreen, I think, is a mandatory thing. It's very simple, it's very affordable, it can be given to all patients, and most patients don't mind using a cream, one cream once, 2 or 3 times a day. Avoid irritant soaps, facial cleansers that can actually cause dryness, because I'm talking about patients I see in this part of the world. People here are very keen on washing their face, and they use usually very, very drying cleansers. And I spend most of my time in the clinic explaining to my patients that it is very important to keep your skin well hydrated. Cleaning the skin does not mean stripping all the oil off your skin. And dryness, I personally believe, definitely leads to pigmentation and accentuation of an existing pigmentation. So if the patient has a slightly darker spot on their cheek, if they dry up that skin very often, that area is going to dry up more and more and look darker and darker with time. So if your patients had dry skin, make sure you advise them not to over dry the skin. They need to hydrate the skin, give them a moisturizer, give them a sensitive skin wash, give them soap-free cleanser, advise them to avoid dryness. Cosmetic camouflage is the last thing I try to give, because I try to treat first and improve. But again, if people are stressed out about it, this is very important because you need them to feel better about themselves. Now start with topical therapies. This helps with further evaluation patient's response and can prepare the skin even for other treatments. So in my clinic, my first step is always give them topical treatments, always prepare them. Even if I'm planning to do more things like peels or use my lasers on them, then I actually wait and I say, you know what, use your creams for a minimum of 4 to 6 weeks and then let me see you. When they come back, I'm able to actually judge how much they're going to respond. If they do well just by using creams, that encourages me to do more. If they're not responsive to the topical creams, I know that I'm going to have a hard time ahead of me. And then I prepare them that the fact that we might do a lot of things, we try different things and might not change. However, topical therapy is a very good starting point. It gives you the chance to assess your patient, assess the response, and also gives you the time to plan further treatments. Now, this is an interesting study that I came across, which talks about the prevention of recurrence of melasma by triple cream formula. So we're back to the triple cream formula. And trust me, I'm not a fan of that triple cream formula, but the fact that actually a lot of the studies that I came across has really looked into that a lot, I think it was worth bringing it up more and more in this talk. In this study, 242 melasma patients from Brazil and Mexico were actually achieved clearance or mild disease after they were treated daily with the triple cream formula. Now, in the study, they went to maintenance phase, which was basically for 6 weeks, and around 78.8% of the patients were entered. Now, patients randomized to receive the triple cream twice a week or a tapering regime 3 times a week for 1 month, then twice per week for 2 months and once per week for 4 months. After 6 months, 53 remained relapse-free. I don't know about you, but I do find it hard because a lot of the time you help the patient to clear and they look better. And then they disappear and they come to you like 6 months or a year later and they say, okay, doctor, it's back, nothing happened. It's like I haven't done anything. Yes, these cases require maintenance. Now, whether you decide you're going to try the triple cream formula maintenance, whether you want to use other topicals, whether you want to encourage them just use topical and sunscreens and moisturizers, you have to put them on maintenance. It is very important because I always tell the patient that the recurrence is high, relapse is common. I cannot take away all your pigment, so you'll have to do something about it all the time. Now, what is the best maintenance regime you want to put your patients on? That is something I leave to you, and you have to decide it depending upon your patient situation, upon their response, and also keep in mind their budget, their lifestyle, everything comes into account in this. Now, ochronosis, since we talked about hydroquinone and the triple creams, we have to talk about ochronosis. We've been always worried about this. And I'm sure most of you have seen exogenous ochronosis, and I've seen it in Bahrain a few times. And it's been always an issue. Whenever we use the hydroquinone and when it had its 3 months restriction, we were very, very strict about it. And I personally never use more than 4%, and then I usually try to go down to the 2%. Now, to be honest, looking through the literature, all I found that exogenous ochronosis is not supposed to be very common in a medical supervised situation. So if the doctor is giving it and he's following up his patients and they're supervised properly, then this should not be an issue. It is more likely in the unsupervised cases. And unfortunately, it's an abuse of lightening creams, which happens in various countries in the world. It's very common in places like Africa, in certain parts of Asia, and even in the GCC states. Unfortunately, there are women who sell these mixtures of creams at home, and they sell them usually to people with very dark skin, promising them fairer skin and lighter skin. And this has always been the issue. So maybe the bad publicity or the bad, basically, how far we are worried to use, how far you could, or how long you could use hydroquinone for, has always been an issue. The other thing that is also very important with ochronosis is that hydroquinone is not the only reason you could get it. It's actually the other ingredients that's often added with the hydroquinone in these primitive formulas, like mercury, phenol, or resorcinol, and in a very unsupervised, unprofessional way is usually what also leads to that. So let's not blame hydroquinone use or the triple cream formula for long, because as I said, most of the literature has spoken about the abuse, the coming in contact with other ingredients, and the poor medical supervision. I think a different issue with hyperpigmentation that is again common, I'm sure we all see it, is the issue that we see with pigmentation in our clinics, especially in our part of the world with our types. It often follows inflammatory dermatosis. So any inflammatory dermatosis, we can see it following eczema, following psoriasis, following acne, following surgery. Often people come
Dr. Nadal, we lost you. Could you please reconnect, because the connection on your side was lost? Could you please reconnect? So we have, I guess, a connection issue on the side of Dr. Nadal. So she will reconnect. Kindly please just wait a few seconds for the reconnection. Dr. Nadal, can we hear each other again?
I can hear you. We disconnected for a reason.
Yes, we lost the connection on your side. So just come back a few slides, share again your presentation, and come back just a few slides. We lost you the last minute.
No. Okay, we'll come back.
Welcome back. Welcome back. Just kindly share again your screen and your presentation, please.
I'll go. You're okay now?
We still cannot hear. We still cannot see your screen.
New share. Let's put a new share.
Yes. Now you started to share. Okay. Okay, now it's good. Thank you so much. Just kindly repeat the last minute of your presentation.
I'll go back to the post-inflammatory. I think this is maybe when we had lost connection, right? Can you hear me, Vineta?
It's good now. It's good now. We see your presentation and we can hear you.
Great. Okay, so I think there's an interruption with the connection. I'll just go back to the post-inflammatory hyperpigmentation slide quickly in case you haven't heard that. Literally, we were talking about the post-inflammatory hyperpigmentation being a very common issue as well, especially with skin types between 3, 4, and 5. It's often following inflammatory dermatosis, which means eczema, psoriasis, acne. Anything can give you post-inflammatory hyperpigmentation. Again, it can be caused by chemical or thermal injuries, including the use of lasers, for example, chemical peels. It's more common in dark-skinned people. It is temporary, and it should be temporary, but the length of the post-inflammatory hyperpigmentation to recover often takes a very long time. We tell people it's going to go away, but we know it takes between sometimes a year to 18 months sometimes. Usually it's very distressing to patients, and most patients refer to their skin as being sensitive because they develop that. And that's often not the case. It is the fact that with darker skin types, you're more susceptible to get hyperpigmentation following any inflammation or trauma. Now, topical treatments, again, as in melasma, hydroquinone, azelaic acid, in this case, has been also tried, vitamin C based products, they can help speed up recovery. Now, this is an example of a lady who presented to my clinic after doing a chemical peel in another clinic. So she came, and you can see in her, actually the photo on the left, you can see where they did the chemical peel. And she came because she was, at the time I saw her, she was very inflamed and red. But then when she healed, you can see that she healed with a post-inflammatory hyperpigmentation at the location where she had her chemical peel. Therefore, it is very important, if you are to practice chemical peel in our region, is to actually start with a low concentration, test the skin, allow your patient to have multiple sessions. Don't be aggressive, because they're not happy when you leave them with PIH that lasts for a very long time. And they'll keep going to different doctors trying to resolve that issue. Again, this is another example of post-inflammatory hyperpigmentation. We can see one which is following acne vulgaris, and again, acne in young ladies and young men in our area usually is followed by PIH. The post-inflammatory hyperpigmentation, very common, and most patients refer to it as scars. To them, this is scarring. Now, they're reassuring that this is not scarring. However, the pigmentation is still distressing, and although we know it's not gonna last forever, they always come to you looking for a treatment. Now, with such patients, usually preparations based on azelaic acid and retinoids are helpful and useful if you're treating patients like this. With acne, it's also good to try and avoid things like minocycline, which can actually sometimes aggravate the pigmentation. So looking at what happens after they get acne can also make you decide what is the best option to treat these patients. Now, the other case you see here is a lady who had her PIH after hair removal laser done on the face and neck. And you can see exactly where the laser was shooting. And this is usually when cooling of the laser is not enough. So it's usually referred to as a cryogen failure or an ineffective cooling of the skin before the use of the laser. So again, when you're using your lasers, be careful. Laser hair removal, PIH, I've noted that it actually stays for a very long time and requires a lot of treatment. This patient actually had hair removal laser done in another clinic. She came to me because she hated what happened to her face, and she couldn't explain why doing a laser hair removal gave her all these spots. And I did treat her. I will show you the results later. But again, keep in mind, laser hair removal is very popular. But again, patients, when they're left with this, not very happy. Another common we see it on the face, and it's very common actually, I find in our age, the facial acanthosis nigricans. Again, acanthosis nigricans, as we all know, is a marker of metabolic syndrome, and this is actually a study that actually talks about 123 patients with facial acanthosis nigricans. When they compared them to sex and age matched groups, the mean age of onset was 31 years, and they had high insulin in 37% of patients. Again, it seems to be more common in male gender. They usually have positive GTT or glucose tolerance test, increased waist-hip ratio, increased body mass index. This is, for example, this is an example of a facial acanthosis nigricans. Of course, the patient has also some deep acne scarring, but again, this is a lady who will complain to you about hair pigmentation. You have to look into the possibility of her being an insulin resistant. There is a tendency for diabetes. We need to advise them on losing weight. These are all important in planning the treatment for these patients. Again, another lady with facial acanthosis nigricans. You've seen this. This is actually a lady who I attempted to treat, and there is a slight improvement, but again, it's usually a darker lesion that actually goes below the zygomatic bone. So usually it is more here. So it's not like melasma. Melasma is a bit higher. This is a bit lower, and you see it more on the sides of the face, and it can be seen in both men and women. And most of the one you see is usually people who are overweight. Another hyperpigmentation that we see on the face, and again, I see it quite often, and it's probably common in our part of the world because of the skin types we deal with. More darker skin types, more olive skin types. There is the pigmentary demarcation lines, which probably you're familiar with. The demarcation lines, they were first described in 1913. They are common in Black and in Japanese population. But again, it is very commonly seen now in the Asian population, in the Arab population. You see it more with female than male, and it affects face and limbs. There's no real etiology that is, there has been, looked into the literature, there's a lot of proposed theories. Some of them are related to the neural origin, some related to hormonal, some just for the different ethnicities. But nevertheless, it is something we see. Patients come and complain about it, and I find that this is one thing I can't do much about. And it's usually something that you probably just have to advise your patient just to use a good sun protection, and usually doesn't respond much to standard treatments. Again, the demarcation lines in the body, probably some of you are familiar with the fact that a lot of women during pregnancy, they develop these demarcation lines on the back of their thighs. And you see like the external side is a bit darker, the internal is a bit lighter. And in this case, usually this resolves after delivery. And again, it's not understood why it happens. Some people relate it to the hormonal changes, and some they relate it to the fact of the pressure on the neurocutaneous bundle. I'm not sure this is really a good explanation, but this is something we see. Patients ask about it, common in Arab skin and Asian skin, so we should know about it. This is an example on the face. This is a patient who these are two patients actually, two different patients. They're both Bahrainis. They both complain of this demarcation line extending from their corner of the eyes coming down to the cheek, and the color is usually very smooth, very soft. I did try with both of them to clear the lesion or lighten the lesion topically using lasers, using peels. Neither of them responded, so I told them, just don't do anything, just use your sun protection religiously. I don't think we can do much about this. Again, this is another lady with the side. You can see the extension coming from the side of her cheek. It usually starts also from the corner of the eye. Another example is actually around the mouth. Is usually at the angles, the corners, the angles. This dark line coming down from the corner of the mouth to the chin. Another reason for facial hyperpigmentation is drug-induced. This is very important. We have an increasingly aging population with lots of medication. I think all dermatologists should take a thorough drug history. When patients walk into your clinic, ask them what is their medical history and what medication they're on. Most of the patients now are very well informed. They know their medication, and if they don't know them by name, they have their photos and their phones, so they can show you what they're using. And a lot of variety of drugs can cause facial hyperpigmentation. I've listed a lot of them here, but if you read, they are very common, especially steroidal anti-inflammatories. Phenytoin, amiodarone, antimalarials, antipsychotic, anticonvulsants, cytotoxic drugs, tetracyclines, and heavy metal. This is an example of one of my patients who actually had a drug-induced hyperpigmentation because of the use of non-steroidal anti-inflammatory, and she was also on amiodarone. And this patient came because she wanted this pigmentation gone. And for me, I had to explain to her that I personally think that her medication has a big role to play, and I cannot promise that this pigmentation will go away. One thing about the drug hyperpigmentation in the face, that it crosses the jaw. You see it on the face, and then it actually crosses down to the neck. Most of the, for example, with melasma, the pigmentation stays on the cheeks or high up. But with the drug-induced, you will see that the discoloration is almost everywhere, and it continues to go down to the neck, and it doesn't spare even the sun protected areas. So I think this actually gives it away. So when you see patients with this, always think about their medication. The medication is usually they've been using it for some time to cause such effect. A lot of patients, for example, who come to you with connective tissue disease and they are using Plaquenil or hydroxychloroquine, they've been on it for a while and they start getting that discoloration. And a lot of them come and say, can I do laser to get rid of this? To be honest, not much can happen until they are off these medications. There is a very I don't know if this is popular or common. I don't think it's very common. I think I've seen one case. It's lichen planus pigmentosus, which is a macular variant of lichen planus of unknown etiology. Basically, the patient gets like a grayish blue or a brown black macule, and it's usually more in a photo-distributed manner. It actually usually affects more the side of the forehead. So you see it more on the side of the forehead rather than the center as in melasma. And then it can extend a bit. It is more likely to be seen with darker ethnicities. It's been described a lot with Black American, people of African origin. The triggers, we don't really know why it's happening, but there are some trigger factors, and sunlight is considered one. And there has been some reports of viral infections. Topical agents used like oils, henna, hair dyes, a lot of the way you style your hair, and probably that's why when people use like oils heavily on the for styling the hair, or probably using hair dyes, using henna, using the wig that sticks on the forehead. Some people have related it to it, and this could be one of the reasons. There is no effective treatment. I did personally try with the case. I saw lightening agents. I encouraged some protection. I asked them to avoid using hair oils and hair dyes. The lady I saw had a wig on, so I asked her to put the wig high up, not on the forehead. Topical steroids, I used a Q-switch Indiac on her, but I don't think that made a difference. So now I'm trying to use a little bit of a glycolic acid peel on, which helped a bit, but I think this is again a very difficult condition. This is the lady I'm talking about, and you can see the side of her forehead has this discoloration. This is why she came, actually. She has a beautiful skin. She's a Black American, and this lady actually just has the pigmentation on the sides of her forehead. Finally, there is the maturational, or what people refer to as maturational hyperpigmentation. And this is a form of pigmentation that comes probably with age, menopausal, hormonal changes, also triggered by sunlight exposure over years, can be also accentuated by use of certain medication. So I think at this, and if you look at it, it also seems to start around the eye, moves down. So it's probably a combination of different things, but that comes more with age. And usually most women who come to you at this age are women who are in their menopause, or they actually started, noticing this after many years of having not to worry about their skin. Also, most of these women are women who haven't really used a lot of skincare. So if you ask her about the history of what skincare she used, she's probably never used a sunblock, didn't really care much. She'll tell you, I just wash my face with soap and I'm fine. So I see it more with women who actually never bother to use any skincare. And one thing I encourage them to do is to start using skincare, and actually they do notice a difference, because I think sometimes if you've never tried anything in your skin and you start using it for the first time, it makes a difference. It's a combination of hydration, sunscreens, vitamin C based products, and sometimes I offer them lasers or gentle peels. Never go over the border with these ladies. We've talked about topical treatments. We've talked about alternating with peels. And now I will mention a little bit about lasers for melasma and hyperpigmentation, because various lasers have been proposed. A lot of patients come to you and they ask for a laser treatment because they think laser is a solution for anything that is difficult. So we need to know about what lasers we could use and what could they do, and what are actually the possibilities or the possible outcome of such patients. Now, various lasers have been used for melasma. One of them is the green light, like the PDL, 510 nanometer, frequency doubled Q switched in DIAG, the Garnet 532 nanometer, and this is more used for the epidermal pigment. The red light, or the Q-switched Ruby 694 nanometer, and the Q-switched Alexandrite 755 nanometer is also been used, but more for the deeper pigments. The Q-switched Nd:YAG 1064 has become very popular treating different vascular lesions, including pigmented lesions. A lot of the time with treating pigmentation, there is a vascular component. So actually targeting the vascular component in the pigmented lesion can help to improve the pigmentation in these patients. Fractional lasers, I personally not a fan of using them with hyperpigmentation and melasma. There's also the fractional radio frequencies, and there is the CO2 laser, which I do not personally like for our skin type, and I think it's very risky to be used in darker skin. This is actually talking about a randomized controlled split phase study of the efficacy of picosecond laser in the treatment of melasma. So lately, the picosecond laser have become like the new thing for hyperpigmentation. Companies are telling us that these are safer. You can use them on all skin types. They are very effective and they can take away the pigmentation. They are also used for tattoo removal. So if we're talking about these lasers, basically they work on anything that has pigment. In this study, there was 10 subjects, so it's not a big study, where they received a 9-weekly treatment using pico laser, and it was given to half their face. So it was randomly given to half the face. Also, they were given lightening cream to apply all over the face as a control. The clinical efficacy measured by the melasma index and a questionnaire and physician assessment. Overall improvement was 80% on patients on the laser side versus the 20% on the control side. They had minimal side effects, just transient erythema, discomfort during or post-treatment, but nothing of significance. It's a very small number. However, it is randomized, it is controlled. Of course, we need bigger studies with more numbers. But again, this is actually promising because it's giving us another thing we can do with our patients, especially if you're seeing a huge number of hyperpigmentation in your daily practice. You're always looking for something new to do. And keep in mind that lasers have a very positive effect on the skin, on collagen synthesis, on stimulating basically collagen, improving the skin texture. So it's not just that you're trying to get rid of the pigmentation. So of course, we will be looking for lasers that can help with pigmentation without making it worse. Because the general idea about lasers is they can make pigmentation worse because of post-inflammatory hyperpigmentation or rebound hyperpigmentation. And this has been always an issue whenever we want to use a thermal machine to treat pigmentation. This is basically me doing a treatment for one of my patients. And this is I'm using here a pico laser. Again, this is us performing the treatment, and I usually space my treatments every 3 to 4 weeks. This is an example of patients that have been treated using the Q lasers and the pico laser. This patient treated using the Q-switched Nd:YAG laser, and you can see that she's mainly an acne patient who had post-inflammatory hyperpigmentation. So this is acne patients with post-inflammatory hyperpigmentation, and she is a patient who didn't want to go on Accutane or isotretinoin therapy. She wanted to take topical treatment, considered systemic antibiotics, but did not want to go down the road of Accutane or isotretinoin. So what I did is I offered her a treatment with the Q-switched Nd:YAG while she was also receiving her topical treatment and her systemic antibiotics. And she improved a lot. She was very happy that the fact that the marks have improved. So with patients, even with acne patients, if you are trying to give them another option, where it's more suitable for them, or it actually addresses their concern, because this girl, her concern was the pigmentation. Although she's fair skin relatively, she gets more like red marks, but again, lasers can improve with redness, can improve the texture, and if you had PIH, it will also improve it. So we can see that she had quite a good result after 3 treatments. This is a lady who's in her late 40s. She presented with this single lentiginous on her face, and she was very unhappy with it because she said it's just a dark spot in the middle of my face. This one I treated basically with the pico laser, and I actually targeted the lesion using 1064 and 532, which made it darker at the beginning, but then it started to lighten. So you can see after the first session and then after the second session. I'm sorry. Again, this is the same patient you saw earlier who had laser hair removal on her face with post-inflammatory hyperpigmentation. I treated her with a pico laser, and you can see that her skin cleared. You can see remnants of the PIH. This girl received 3 sessions. They were spaced at 1 session every 4 weeks. In between, I gave her a lightening cream and I gave her sunscreen to use, but actually her main work was with the laser. This is another patient who actually received treatment with the pico laser, and you can see she's a case of melasma. In her before picture, you can see the patch on her cheek clearly, and this is after 3 sessions with pico laser. And this particular patient was very, very worried about using lasers. So sometimes to convince a patient to do a treatment, it takes a lot because they don't want anything to go wrong. And again, you have to be careful. So my advice would be, whenever you start something like a laser treatment for melasma, keep an eye on your patient, follow them closely. Don't over-treat. Always try to start with a lower fluence, you do minimum passes, and then see how your patient responds. This is the same patient, but it's from the other cheek, and you can see the improvement in her melasma before and after. So if we want to have a treatment algorithm for hyperpigmentation, I would suggest, if you have an acute case of hyperpigmentation, patient never been treated, they present to you, it's acute onset, just started, be a bit aggressive. If you're going to use topical, go for hydroquinone-based formulas, use triple combination cream. You can have your own compounded creams, depends on which country you are, and I know that a lot of countries, they have their own compounded formulas. Tranexamic acid, I think, might work if you start early. Peels, lasers, again, that is an option, but remember what I said about peels and lasers. Don't be over aggressive, don't over treat, because you can end up with hyperpigmentation or a rebound hyperpigmentation. Maintenance, you've cleared your patients are better, you cannot leave them. Even if you haven't cleared them, but you use, that is an option. So remember, maintenance is very essential. We read the last 2 slides. So there are causes of facial hyperpigmentation. Is responsive to many pigment is often present. Therefore, improved epidermal pigmentation is not difficult. Usually, we know remains the most chemical riches are effective, can cause irritation. Hello.
Dr. Nadal, we lost you again. Could you please reconnect again as the connection was interrupted? Just kindly to reconnect again.
Okay, sure.
Welcome back. We can hear you. I cannot just kindly share your video as well.
Screen, you share. Okay. Now, where is my 1 second?
Okay. Welcome back. Welcome back. We can hear. We can see you. Okay.
You can hear me?
Yes, we can see you and hear you. So now it's okay. Welcome back. Okay.
Perfect. Sorry about that. I really
technical issue that it's not under our control, unfortunately. We depend on the internet connection from many sites.
I'm just going to talk about, these are the last 2 slides. You can hear me now?
We can hear you. We can hear you. Okay. If you have still more slides, you can share them. Just
this is we were talking about the conclusion. It is very important to get the correct diagnosis for the facial hyperpigmentation. Hello?
Yes, we can hear you.
And the correct diagnosis is very essential before choosing any treatment. In my talk, I've described various causes for hyperpigmentation. Probably we emphasized the talk on melasma because melasma is very common. It is often caused by increased epidermal pigmentation that is responsive to many treatments. However, the dermal component is usually the part that disappoints us a bit because it is often present and a lot of the treatments don't make a huge difference. Lasers can be of use in such cases. Hydroquinone remains the most effective depigmenting agent. Topical retinoids are effective but can cause irritation. You can help your patients who get irritation with topical retinoids by telling them to use a moisturizer before using the retinoid. That can help. Topical steroids are also helpful to stop irritation, but remember they can cause skin atrophy and telangiectasia, so always examine the skin for such changes. Now, a series of pills can be used to help speed the recovery of your patients. So pills are good if used properly and correctly and under medical supervision, and you're monitoring your patient's response, and it can actually speed the recovery of such patients. Now, lasers, again, there's new lasers with various wavelengths, fluences, different pulse lengths. These are all promising. However, keep in mind, hypopigmentation, rebound hyperpigmentation still remain an issue. We still need more studies, and we need to hear from people who have experiences with lasers, especially in darker skin types. Sunscreens applications and avoidance of ultraviolet and visible light are essential. I did not talk a lot about visible light, but remember that actually visible light has shown to contribute to the effect of hyperpigmentation or worsening hyperpigmentation. Maybe I need to mention one thing: smartphones, iPhones, iPads, these screens, computer screens do not actually contribute to hyperpigmentation. So hopefully that's good news for some people. And thank you very much for listening.
Thank you so much, dear Dr. Nadal, for the excellent presentation, very informative, very detailed, with the overview of all the hyperpigmentation disorders, your treatment guidelines, protocols, your cases, very interesting, and your advice and sharing also what's the latest discovery, scientific and news. And I thank the attendee doctors. We had a great attendance rate tonight. I'm really thankful and I'm so happy to have this forum. Now, let's continue. We have a few questions in the Q&A section. So I will be going through the questions. The first one is, what is the protocol for melasma with very dry and very sensitive skin? What would be your protocol for treating melasma of a patient with very dry and very sensitive skin?
Well, the first thing I would start with is actually solve the dryness. I think, as I mentioned in my talk, dryness is a very issue, especially in our part of the world. And we have to see if they have a reason for the dryness. Is it their daily practice? Is it that they have issues like hypothyroidism, or they have vitamin D deficiency? Again, very common in our part of the world. So look at your as a whole, solve the dryness, give them soap-free cleansers, encourage them to use moisturizers, and then start using your whitening formulas. If you want to introduce whitening creams or you want to use a triple cream formula, make sure you do that after you've encouraged them to improve the dryness. Because the problem with using any of the whitening products is the irritation. The other thing, even if you're considering using something like vitamin C formulas, make sure that your vitamin C formula is not just vitamin C, because it has more also according to their protocol.
We seem to have a connection issue again. Let's see if we can reconnect for the last questions that we had. If we still have the connection issue, then we will kindly ask Dr. Nadal to answer the questions, and we will share in written form with all the attendees. So let's see if it's still possible to continue. Dr. Nadal, can we hear each other?
Yeah, I can see you.
Okay. In case we keep having the connection issue, we can just kindly proceed with the questions in written form and additionally share the answers with the attendees.
No problem. But can you see me now?
Yeah, we can see you. Now you're sharing your screen. Okay. So we can proceed with the second question. We know melasma is recurrent. So once the treatment is finished and we see clearance, what do you normally suggest as long-term option along with regular use of sunscreens? Do you recommend regular peel sessions every 6 months?
Yes, you can do that. If it's, again, if you're going to do the peels, I think most of the patients and then you can make sometimes I combine for a very short period.
Can you hear us?
الفيلم اللي احنا فيه ده. Okay, I can see you. Can you see me? No.
We can see you too. We had another interruption. So the suggestion is if we have one more interruption, just to kindly share with you the questions, and if it's possible that we have your answers in written to share with attendees. In addition,
I prefer to directly. So
yeah.
May I continue my answer from the previous question?
Okay.
I mean, the question was whether how often you would do the peels. As respected doctor asked, using the peels every 6 months. There is no standard. It depends also on your patient situation. A lot of patients, for example, they come back and do peels after the summer holiday because they've been spending a lot of time in the sun, and there is more recurrence of their pigmentation. However, keeping the patient on a regular maintenance regime is very, very essential to prevent relapse. If you are to choose whether you want to use hydroquinone-based formulas or hydroquinone-free formulas, or anything that you're more familiar with or is available in your own country, go for it. And you have to tell your patient that if they stop doing that, then their pigmentation is going to relapse, and probably they have to start all over again doing all the treatments. So most patients really want to continue with their maintenance.
Okay, thank you so much for the answer of this question. Our next question is, in case of using Q-switched NDIAC for melasma, do you treat all the face or pigmented patches only?
Actually, I tend to treat most patients, I treat the whole face, because when I'm treating with the Q-switched NDIAC, I am targeting the melasma or the pigmentation, but I also tell my patients that I will give you a whole face treatment because I want to rejuvenate the skin and stimulate collagen production. As I said, with lasers, you do have more benefits. So give your patients all the benefits. However, the focus is usually on the affected areas.
Okay, thank you. Next question. How do you deal with friction hypermelanosis on bones of Hidano, which is a common complaint of females in our area, mainly elbow, knees, and sometimes ankle joint skin?
I usually, first of all, I make sure there's no dryness, because a lot of these patients have very dry limbs, like dry elbows, dry knees. I let them know that friction is out of question, no pressure on the area. This is very important. The third thing I actually do as a treatment in the clinic is I alternate actually peels with the laser. So I either use the Q-switch NDIAC or the Pico laser, alternatively with glycolic acid peels, for example, or retinol peels.
Thank you for the answer. The next question is about retinol in the treatments.
Okay. So, okay.
Yeah. How do you use retinol? Maybe concentration in combination?
Retinol, actually, oh, sorry. Can you see me?
Yes.
Okay. Yes, I use it either as part of the triple cream formula. So if I'm using it as an induction treatment, or using it in acute forms of pigmentation. So I'll use it in combination with the steroids, topical steroids, and with the hydroquinone. I usually go for like 4 to 6 weeks, and then I try to stop and move on. However, after that, in a maintenance formula, I usually use it 2 or 3 times a week at night on its own. So I usually go for a mild form, like a retinoid form, 2% or 0.025%. It depends on what my patient can handle. Some patients, they can handle higher concentrations, some they need lower concentrations. The good thing about the retinols, now you have a lot of formulas in the market that have been produced by different cosmeceuticals that are not very harsh, and they're very well tolerated. So I actually tell my patient to use it at night, and I alternate that with a hydrating serum or a hydrating moisturizer on the other night.
Okay, thank you for the question. So as a part of Kligman trio, and then as a maintenance from a cosmeceutical producer. Next question, Dr. Simonovic is thanking you for the excellent presentation, and I would like to ask, what is your treatment approach in acanthosis nigricans? I think you showed the case about that in your presentation. Maybe just briefly
as I said in my presentation, you have to target the origin of the problem. So if we're talking about acanthosis nigricans, then overweight, obesity, this has to be talked about. Unfortunately, childhood obesity is common in our area, and that's why we're starting even to see this in young children. So it's very, very important to reduce weight, tell the parents that this has to be started very early in life. In adults, I emphasize that nothing is going to change unless they lose weight. I also make sure that I get them tested for insulin resistance and to do a blood sugar level test. And I look into all that, and then I offer treatment. So my main approach is first to let them know that this is only a presentation of an underlying problem. So I need you to do something to help yourself before I give you any creams and lotions and potions. So there's nothing magical about it. The patient has to do his part in this.
Okay, thank you for the question. Next one, what about high concentration of azelaic acid? And it exists in cosmelan and derma-alelan products.
Yes, I mean, azelaic acid is very effective, and unfortunately, at the moment, it's used over the counter heavily by our patients. Sometimes it's used or it's an abuse. It's very similar to hyperpigmentation. At the moment, people are using it as a lightening agent, even when they don't have an issue. Unfortunately, it can give you irritation. And most of the time, patients who use it on their own, they present to us with the side effect. So I like azelaic acid. I like different preparations of azelaic acid, and I do use them. And I think it should be used under supervision by your doctor. However, the problem is that, for example, in our part of the world, it's over the counter. A lot of patients have used it already. Higher concentrations are available more in the clinics. Again, I use them just temporary for short period, but for maintenance, I usually try to go for the milder concentrations. But they're very, very effective.
Okay, thank you. Next question, what measures to be taken prior to using cyclocapron orally?
What measures? I think you can actually ask your patient to be very vigilant with their sunscreens. But I don't really use it, so I wouldn't be very keen on it.
Okay. Next question, Dr. Fatima from Pakistan. We have doctors also from Pakistan. What is the effective treatment for dark knuckles and dark upper lip and chin area common in our region?
It is very common, and I did talk about something a bit similar, which is demarcation lines that actually happens around the mouth, happens around the eye. And this is actually to do with our ethnicity, with our tendency for pigmentation. It can be aggravated by dryness. And I think if you actually target, you focus your treatment on getting the patient treated for dryness and avoid drying agents, you can actually succeed with these patients. However, there will always be like a remnant of color in that area. And sometimes you can't do much about it. Around the mouth, one of the things you can try is using Q-switched Nd:YAG lasers. They can work actually for lips and for around the mouth. And especially if the patient has an associated dark lips. And then you encourage them to keep using a good moisturizer, a good lip balm, hydrate the skin, use sunscreen. You can actually achieve some improvement. For the hands, it's usually actually the dryness. However, keep in mind, if you're a skin type 4 or 5, this is a natural phenomena. So sometimes we can't do much about it.
Okay, thank you so much. Next question. What is your opinion of mesotherapy with various agents along with microneedling for pigmentation and melasma treatments?
Well, you can use your microneedling as a vehicle to deliver the. You can. Is it effective though? That's the question. I've shown you a case where I used the tranexamic acid with my patient, and I actually did administer it using a mesotherapy gun, and then later I decided to inject it intradermally. I'm not sure how effective they can be. I personally find that you can use vitamins topically, just applying it on the skin. It is as effective as trying to inject it in these patients. So I think with these products, there's a lot to be considered. I don't offer my patients mesotherapy as a treatment for pigmentation.
Okay. Next question from Dr. Arshad. Thank you so much for such an informative talk on his side as well. Please share your experience about the most effective treatment for dermal and mixed melasma.
Okay, I think we've talked about that. This was almost actually most of the talk. I think let's put it into words. The most effective, I think, hydroquinone products, base products are still very important. They're still very effective, most affordable, available everywhere, should be given under supervision. Number two, you can actually use peels and alternate this with topical treatments, and if you have the right laser, not any laser, if you have the right laser, you can actually use laser therapy. Maybe I think the most effective, I would say in my experience using these variable lasers, is using the Pico laser, because of the fact that the thermal energy is much less when it goes deeper, so you're less likely to get rebound hyperpigmentation, but you're still going deep, so you're reaching the dermal level, and that comes more in an acoustic type of energy, so it's thought to be safer on people who have darker skin types as well. So maybe if you have a chance to try the Pico second lasers or even Q-switch lasers, you can have some success with the dermal ones.
Thank you for the answer. Interesting questions we have now. Which topical medications would be safe in pregnancy and during lactation periods?
Azelaic acid is quite safe. They can use it. I also use the cosmeceutical brands with arbutin, vitamin C. I don't see an issue with that. But azelaic acid out of like medical preparation, you can use.
Okay, thank you so much. Next question, what is the maximum fluence you go with Pico laser?
It depends on the machine you have, isn't it? I think a better question would be is, do you go more for 1064 or the 532? So I think if you read the literature, the 532 is the one that works more. But with our skin type, 532 can give you hyperpigmentation for a while. I mean, it's probably going to be temporary, it's going to fade away, but you don't want your patient thinking that you made them worse than better. So I'm more keen on using 1064, which actually works a bit slower and takes time to show results, but it keeps your patient happy and more trusting you, because they don't see that it's getting darker. But sometimes, like the patient I showed you with lentiginous, I actually did use for them for her 532, and she went darker for a while, but then it lightened beautifully. So I think it's more of the wavelength. Now the passes and the number of passes, mind you, this varies, because actually you can do more, you can do less, depending on the reaction you see with your patient. I've actually even tried using Pico lasers with a fractional head, which comes with the machine, which is supposedly makes it stronger and more effective. But again, the patient become more red and more erythematous. So to be honest, I think it depends on the machine you have. I'm still using my machine, I'm playing with it, I'm trying different things. But the one message here is, whatever you do it safely, use the lowest fluence to start with, and build up your fluence according to your patient's response.
Thank you so much for the answer. Next question. I think more or less we touched the next question, but okay, what is the best treatment for your experience for persistent perioral hyperpigmentation with avoiding factors?
Actually, I think the best treatment, most of the time they do have a bit of perioral dermatitis. So you will probably give them a bit of topical steroids to start with. And then I try to, if the dermatitis is not persistent, I try to move to non-steroidal formulas. Things like tacrolimus or pimecrolimus creams, and that's if they still have an issue. But I encourage moisturization, I encourage hydration, I ask my patient not to bite their lips. If they don't have a proper bite, I ask them to see a dentist to get it sorted. So I try to go around it. I did use lasers in some patients who had like quite a dark area, but most patients do well with just topical preparations.
Thank you. The next question, I think also you already answered, how to choose between wavelength laser between 532 or 1064. I think
the lighter skin. So if you have a lighter skin, you're safe. Go for 532. If you're dealing with, let's say, skin type 1, 2, and 3. But if you have 4, 5, and 6, or let's say in particular 4 and 5, I would say start with 1064 and then try to use 532. It's just safer.
Okay, okay. Next question, is it mandatory to have skin analysis device, like skin analysis machine? What is it, its principle of action? Is it Wood's light?
No, it's not essential. It's an addition to your practice. You don't need it. You're a dermatologist. Dermatologists, we have a trained eye to examine, and we don't need these machines. I just happen to have one. So I use it sometimes. I sometimes use it to test myself. Like if I examine the patient and I think that I've seen this and this and this, sometimes I assess them with the skin analyzer. It is more of, actually, it's more for your patients than for you, because some people have heard about it and they want to see how their skin changed after treatments. But I don't think it's something that is necessary. It is good when you demonstrate the difference. It's good when you're trying to give a talk and show the difference in these patients, because it is an objective basically a method of assessment, but it's not essential. Now, Wood's lamp, again, it is considered a way to look into the depth of your lesions, but I also use my dermatoscope with these patients. It depends really on how you've been trained to look at skin lesions and how do you assess your patients. And I believe every doctor has his own way that he is more comfortable with. So there is no standard way. These are all basically tools. You choose to try them, use them, or not.
Okay, thank you. Next question is about cyclocapron ampules. Is it the same as intramuscular ampules, and how to inject with dilution intradermally?
Sorry, which ampules? I didn't.
Cyclocapron ampules. If I say correctly.
Yeah, you can inject intradermally, or you can use it as a meso. Some people use it like as meso, but I would be careful with intradermal injections. Because I've seen people who've been injected in other places. Like a patient came to me, she was injected in her knees, and it did give her hypopigmentation. So I'll be a bit careful with the injections. Yeah.
Okay, thank you. Next question is about tranexamic acid. Is it necessary to do a blood test before treating with tranexamic acid?
It is. Well, you can. I mean, there has been a report of issues with protein S deficiency patients, which is not a very common condition, but you can if you like. But I mean, I had only one patient who was taking it, and she already brought it with her from the UK. And she used it for 3 months. She was absolutely fine. It didn't give her any side effects. So I think you could, if you like, but I don't think it's absolutely necessary.
Thank you. We have a couple of more questions here and one question from the Facebook group, which we are also streaming live. So is nano-needling better than microneedling in treating melasma? This is a question from Dr. Huma Abbas from Pakistan.
Okay, sorry, could you repeat the question, Vineta? I didn't.
Is nano-needling better than microneedling in treating melasma? This is a question from Pakistan.
I personally didn't try the well, I had a machine that claimed to do nano needling, but I wasn't a big fan of it, so I never used it. So I cannot comment on that. But I do use microneedling. I don't use it particularly for hyperpigmentation. I use microneedling more for scarring and when I'm treating scars. But I can give you a comment about microneedling. Microneedling, I personally think it helps with scarring quite a lot, especially if you're doing it properly and you're doing the right depth. I like it combined with lasers and radiofrequency machines. And I use microneedling with PRP. I use it with meso products. It depends on the case I'm dealing with. And I think it's a very useful tool, especially in darker skin types.
Thank you. Last question here. When you talk about Q-switched NDIAC laser, do you mean 1064 or 532? We already talked about that, but let's once again clarify on that question.
1064 mainly. And with the Pico laser, I use the 1064 and the 532.
Thank you. And the last question we have from Professor Mustafa Abu Zaid from Kuwait, from the Facebook eye dermatology group, where we have the streaming of this lecture live at the moment as well. How do you treat lichen hyperpigmentation? You had such a case also in among your cases that you showcased.
I think we all start in the same way. We all start with topical steroids and then we move to whitening agents. I did attempt to use the Pico laser, and I started using that after I got the machine, where I started using it on people with hyperpigmentation. But I still think it's not magical. I honestly think that most of these lesions will take their time and they fade gradually. You can speed it up doing these methods, but still in some patients, they won't disappear before at least 6 months. So always prepare your patient that this is going to take a long time. There's no magic about it, even if we are trying to use machines like lasers, fancy names, big names, but still you will need your topical. I think steroids still have a big role to do, retinoids, and you can add a bit of like whitening agents like hydroquinone if you like, but I think with the lichenoid reactions, it is more the steroids actually that make a difference.
Okay, seems that we have 2 more last minute questions and let's close the session with them. Again, about tranexamic acid, topical or systematic, what would you recommend?
The patient I had, she had them both with her. So I let her continue with her oral and I gave her the intradermal or the meso ones. But there has been actually some studies about the tranexamic, and most of them actually, they combine the oral with the topical. So I think you're probably going to need both. If you can get both, let your patient take both. If you can only use the topical, I think you probably won't be very happy with the effects. But most of the patients who actually travel to Europe, they are quite familiar because they go and see doctors there and they come back with the product. I mean, I don't think we have it in Bahrain. I haven't seen it yet. But most patients will come and ask you about it, especially those who try to find pigmentation, something to treat their pigmentation. And most of these patients are willing to try it. So I think for us as doctors who never tried it before, for example, I let this patient take it because she was happy to take it and I followed her up. And for me, it was a learning experience. I wanted to see what will happen. Now I can tell you no side effects, well tolerated. It is effective to a certain degree. It's not magical, but the patient was still, I mean, she's still coming because she's seeking more treatment. So it wasn't like a final answer, but it's one option to be considered.
Thank you. Next question is about glutathione injections.
No. Totally no.
No. Which pill do you recommend for hyperpigmentation? Lactic acid, glycolic acid, azelaic acid?
Well, I use glycolic acid 30%. I use glycolic acid 50%. And I use also the retinol peel, especially when I have acne patients like with post-inflammatory on the back. That's it. I'm not a fan of very aggressive peels. I still think that if you use very aggressive peel and end up with a very red skin, you're going to give them hyperpigmentation. So I like soft peels, gentle peels, and I always prepped before and after, and they have something to use at home. My approach, actually.
Thank you so much, Dr. Nadal, once again for the excellent presentation, very informative on both the theoretical part, the treatment part, the question and answer, and we had an amazing forum with doctors in this huge Middle East region, not only GCC. So we are really, really thankful from NAUS because you enriched our eye dermatology forum tonight on the topic of hyperpigmentation disorders. Thank you once again. Thanks to all the doctors attendees to this very interesting webinar, very practical. I'd like to say that we are hoping to see you soon again on further topics and further cases and cases sharing in our eye dermatology forum within the Facebook group. Thank you once again for your time, for your valuable knowledge sharing, and hope to see you soon online in the forum and inshallah live after the lockdown in the live dermatological forums in the region and in Europe and across the globe. With this, I'd like to close tonight's webinar on hyperpigmentation, facial hyperpigmentation, with our special guest speaker, Dr. Nadal Khalifa from Bahrain, and to wish all the participants and our guest speaker a lovely evening and a lovely rest of the weekend. Thank you once again and stay safe.
Thank you. Thank you very much. And thank you all for attending.
Thank you once again.
It was my pleasure.
Pleasure having you too.